Stream status bad.
Yeah, this is computer. We are live. We are live. Notifications are rolling out. We have the notification on the phone. All right.
You're gonna see it has escaped now because of the wasp.
There's a wasp in here. Welcome. It's 1st of September 2018. Live stream number 4 in our weekly live stream series. Welcome everybody who is going to join us today in the chat to have some Q&A, because that's what we do right here. We have some stuff to talk about. Exciting times coming ahead with the new academic year. So let us know where you're joining in from, and I'll give the word to Kai.
All right, hi from me as well. Welcome back to the fourth live stream already. It's going to be the same principles. You can just chat with us, ask us questions, whatever you want to know. Just see it as a relaxed hangout with us. And so just go ahead and ask your questions, and we're going to try to answer them if we can.
Let's see. Okay, people are in the chats. Congrats on hitting 100K. Thank you very much. Yes, we are at 104 something thousand right now. It went super fast after that. But yeah, it was a very nice milestone to hit, definitely on this platform, because this is like where we started out 5 years ago. Yeah, right here you can see almost at 105,000 already. Yeah, pretty cool to see.
Yeah, I think it's going pretty quick, and we're curious to see what's going to happen with the new academic year.
Definitely.
That is going to start on Monday for a lot of countries. So
yeah, lots of new students coming. Hopefully they will find us pretty soon, or that even their lecturers recommend our channel to them if they want to brush up on orthopedic assessment, or even that they're going to watch our videos in class, because I think that's something we've seen happening more and more, that people reach out to us that they watch our videos in class, which is pretty cool.
Okay, there's a question from Rupesh, and he's asking if bow bath is an effective approach for treating stroke. As you might know, we are absolutely no experts on neurological rehab, so I wouldn't be able to answer that question at all. Neither.
No, also
Andreas.
Not me.
I mean, as we said in the past, we have some ideas about maybe someone else taking over the neurological part for our videos. That's still an idea, and maybe something we can put into practice in the future. So for now, we're not a good source for neurological.
We don't know
rehab,
what BOBAT really entails, so we can't say. But you might find there's probably big websites on the BOBAT concept, just like Mackenzie or any other concept that describes what the specific. Shut the door. Yeah.
You're gonna go. Yeah. Okay. Apart from that, Ifra, thanks a lot. Appreciate it, and happy to hear that our videos are helpful to you. That's the goal that we have. So, thanks a lot for the comment. And can't really read your name because it's in Cyrillic, but greetings back to Bulgaria. Also happy to hear that our videos are useful for you. Okay.
Might be a slow live stream today. I don't know. People enjoying the last weekend. It's also pretty nice weather over here in Amsterdam. Because I just came back from Greece, 1 week of vacation. So that's, I was already worried coming back here, having 20 degrees Celsius less than in Greece. But today is actually pretty nice. But yeah, people are probably enjoying the last couple of days of vacation before going back to school or work.
Okay. Mahmoud is asking, do you think I should take courses after graduation or do masters directly? Do you want to answer?
I mean, what kind of courses? I don't, what's holding you back taking the courses you're interested in now, like even as a student? A master's, I think you're talking about two different things, right? Courses they take.
He's asking courses or a master's directly.
Yeah, that's like two different things. Courses you can take any time. I don't think there are any prerequisites. I mean, the masters, you're going to have to finish your undergrad and then go through the masters. And of course, a master's takes at least 1, 2, maybe 3 years. And it's a specialization, like a deep specialization. I don't think that we regretted going into our masters directly after undergrad. You just get a way deeper knowledge if you do a master's rather than any course. On the other hand, stuff that you might learn in a course, you don't necessarily need a master's for that. It's personal preference. Do you want to be a specialist really a clinical specialist and directly go to the masters? Do you want to learn a technique, or?
Yeah, I think we started our masters directly after our graduation. So if you're asking if lack of experience is a problem, for us it wasn't. I think the advantage is if you go directly into a master's program after graduation that you're still in a study mode, because some people find it difficult to work for maybe a year or two and then switch back into the study mode, which can be hard. Yeah, and on the other hand, I mean, you do have more practical and clinical experience, which can help you in a master's program, but it doesn't make such a huge difference as you might expect it. I think for us, I mean, we were also, in our course, there's a couple of people that are way more experienced than we are, but in the end, I don't think the difference is big, and it doesn't have a huge effect on your studies.
I think it also depends on what kind of masters you do. Is it like there are heavily scientific masters that don't necessarily relate to clinical practice that much, and then there are more practical masters as well, where certainly having had previous clinical experience comes in handy. But yeah, I think we preferred it being still in the study mode and continuing pushing through, do 3 more years and then be done with it.
All right, there's a question from Ayesha. Is physiotherapy effective in case of transverse myelitis? I had to look it up because it's not a common case. So transverse myelitis is an inflammation of the spinal cord. The question is, why is the inflammation there? In this case, I don't think that physio is a real treatment option if your spinal cord is inflamed. I think you should see a neurologist. Yeah. And I'm pretty sure that treatment will be mainly via medication. I did a quick and dirty research if there's anything described for physio in this case, and it isn't on PubMed, so at least I can find it.
Yeah, I guess it's subsequent treatment, right? If there's inflammation of the spinal cord possibly resulting in any neurological deficits, neuromuscular deficit, just like in other spinal cord injuries, there possibly can be an application of physio, but if the primary diagnosis is made, that's going to be pharmaceutical treatment.
Yeah, what I could also imagine is if there's any, imagine that the inflammation is worked out, that you could have some benefit from nerve tensioners and nerve sliders. Yeah. So that's something that I could imagine, but there's definitely no evidence on that. Okay, hey guys, love the videos. Glad to hear. I'm currently studying physiotherapy. You guys help a lot. I have a question. I had an MRI a week ago, and I have disc protrusions from C3 till C7 with some calcifications. Can you give some tips or anything that might help me? My arms get numb every day. They are dead for a few hours after I wake up. It's very painful and I can't do any manual therapy. Now, if both of your arms get numb every day, I think this is also a case where I would tend to refer to a neurologist. I mean, it's pretty hard to say from what you describe because I don't know if you might get numb every day. Yeah, because you have to think of how's it called? Cervical myelopathy, which can be a narrowing of the spinal canal and a compression of the spinal cord in the region of the cervical spine. If this is the case and you get numbness bilaterally and also maybe symptoms in your legs, then this would definitely be something that I'd refer back to a neurologist.
Yeah, especially with bilateral symptoms.
Yeah.
Like that's usually, let's call it a red flag or definitely a precaution. Also, depending on how they progress. But you've had an MRI. I don't know how far the evaluation of that MRI went, if you have seen a neurologist. But certainly bilateral symptoms should be dealt with caution. Otherwise, it's usually with spinal nerve compression and signs of radiculopathy is to avoid the provoking postures and movements in a more acute phase.
He's just saying, well, my neck is very stiff. Can imagine. Yes, my pinky on my left and leg is also dead. Yeah, that's definitely a red flag that we would refer back to the neurologist. So make sure you get that checked out. Because the thing is, in some cases, you have to take the compression of the spinal cord in order to prevent more severe symptoms that might still be there or might persist in the future. So
because there's definitely like multi-level signs of radiculopathy bilateral. So get that checked out.
All right. Pain in the back of the shoulder during bench press, location in the area of acromion. Can you help me out? How can I approach this case? I mean, same story like it's always the same story. If you describe as a case in like a sentence, it's pretty hard to say something about it, also without seeing you in person. In general, if you have pain during the bench press, I mean, or with anything basically, what I'd suggest is take rest for a week, see if your symptoms decrease. I don't know if you have pain at rest, so that's also a thing. If your symptoms don't go away at rest after a week, then you can consider anti-inflammatories like ibuprofen or diclofenac. If they are still not gone, see a specialist, either physio or someone else. If you only have pain during the bench press in the location of the acromion, it could be that your AC joint is overloaded. So our advice would be to take less weight or choose a weight that you're comfortable with and start from there. See if you have any pain afterwards, and then gradually build it up to the weight that you had before. And that's true for everything. Like we both had some knee pain or patellofemoral pain syndrome, if you want to call it like that, because of heavy squatting, I assume. And what you should do in this case is take a weight that you're comfortable with and then gradually build it up so that your tissues can adapt to the load.
Yeah, do you have like same? Do you have problems with any other push exercises, or is it simply just the bench press? And then it's, evaluate your bench press, take some weight off of it. Does that change anything? But yeah, like Kai's first sentence, describing a case in one sentence is pretty difficult. Just gonna, in the meantime, look up something like adapting how you could possibly also adapt your bench press. But we'll get to that later. I'll look it up.
Yeah. How could you adapt it on the floor, for example, so you don't have to go too far into horizontal abduction. Take a closer grip that also puts less stress on the shoulder. Those would be two advices that pop into my mind quickly. Mahmoud is specifying his question like manual therapy workshops or masters in manual therapy. I mean, manual therapy is a really controversial topic and discussed a lot. I mean, we are doing a master's in manual therapy, and the main value of that is not that you have awesome manual therapy techniques, which can be helpful if they are added to good advice and an active approach. But way more important in our master's program is the clinical reasoning behind it. So your whole approach and your knowledge is just way deeper. So it's not so much about the manual therapy techniques. I think you can be an evenly good physiotherapist without manual therapy. So this is, I think, what you should ask yourself. If you really want to be better in clinical reasoning, if you want to have deeper knowledge, then go for a master's. If you want to learn techniques, which I think are overrated and not necessarily, they are not a necessity, then you might be fine with workshops. Could you guys deliver lectures on biomechanics of spine? I'm a third year undergrad, by the way. We created 3 videos about 2 years ago, I think.
Yeah.
About, can you?
Lumbar spine.
Do they see it when you?
I'll look at it.
Okay. So Andreas is going to show you what kind of videos we created. We started making those videos for the lumbar spine. So it was quite a bit about histology. So what kind of collagen do we have in the disc of the lumbar spine? We did quite a bit about movement.
Yeah, it's 4 videos. There's a playlist on our channel. It's called Lumbar Spine Anatomy. Let's see. Do you have WhatsApp open? I'll send it to you, the link, and then maybe you can post it in the... So Kai's gonna post it in the chat. So there's a playlist, Lumbar Spine Anatomy, where we covered like general features of the lumbar spine, outlining what the particular features are. So gross anatomy, but also the function, particular features of the intervertebral disc, also how they serve as a shock absorber, what the orientation of the what are they called?
I just didn't follow at all.
The components of the intervertebral disc and how they serve as, how they can resist rotation and compression and traction. We have the posterior elements, and this is for the lumbar spine. Then also the lumbar spine assessment videos. There is a little bit of, not really biomechanics, but what's supposedly happening in terms of facet joint movement during different PIVMs. But maybe you could elaborate what you're really looking for. Are you looking for what moments are exerted during certain movements, or which muscles exert which levers? I don't know.
Yeah, next one.
Yep, next one.
Best stroke management, please. Like mentioned earlier, we really have poor knowledge about neurological issues, so we're not the ones to ask. Then next question, do you know the Klein-Vogelbach method? If so, what do you think about it? Greets from Poland. I know when I worked in Switzerland, a lot of people talked about the Klein-Vogelbach exercises. Yeah.
I've never heard of it.
There's a lot of exercises for the core with funny names, but honestly, I don't know enough about it to be able to really say something about it. So I don't have enough knowledge about it to be able to give you quality advice here.
The Delphine.
Yeah. Okay. Hey, I have a minimal ulnar nerve compression. What do you guys think? Yeah. But they do have some good exercises, actually. Yeah. Hey, I have minimal ulnar nerve compression. What do you guys think I should do to feel better, like exercises?
It's like ballet.
The best thing that you can do with an ulnar nerve compression, I mean, the question is also where is it getting compressed? And then treat that area. So that could be one thing. The other thing is that you could do ulnar nerve sliders and tensioners, and we also made a video about that.
Yeah,
I'll post a link. Yeah, that was with the one that David Butler did. Which one?
Peripheral nerve sliders and tensioners.
Yes, exactly. I got the link as well. So
sliders and tensioners.
Yes, I can post it. So I'm gonna post it below. Still a link for the ulnar nerve sliders amongst others.
Whoops.
Yeah, exactly this one.
There we go. Yeah, it's this one. So we do like upper limb sliders and tensioners.
All right, what do you think about chiropractic? Udita is asking.
We had that one in the two live streams ago, right? That was like one of the last questions. Yeah, it's, there are good chiros, there are bad chiros, there are good physios, and there are bad physios. I think chiros, I think this question is asked a lot by PTs. I see it on social media all the time, like physios bashing chiros and chiros bashing physios. But there are bad apples in both fields. You have chiros. I mean, the original theory of how chiropractic therapy worked, of this subluxation theory, it's bullshit. But there are also highly evidence-based chiros nowadays. There are physios who work, based on theories and beliefs that are also complete bullshit. Of having a vertebra that's out of place or whatever. There are manual therapists who work on these outdated theories. So I guess I haven't met actual chiros.
No, in Europe there's not too many, and it's not a study that you can pursue in the Netherlands. So you would have to go to England or to the US to do that. I think, in my opinion, everything you do with a patient, like if you manipulate the spine or whatsoever, it should be based on clinical reasoning, on a clinical reasoning framework. So it's not so much about the techniques. It should be based on sound clinical reasoning. And what Andreas also mentioned is that the explanation that you have for why you are manipulating the spine, for example, should be based on what the evidence is saying and not on false, possibly nocibic theories.
Exactly.
Yeah, and that's true for chiros as well as physios and maniotherapists. So yeah, depends on the guy that's giving the treatment. All right. Let's see. What is the best exercise database out there? I think you know that better than me.
Like, what are we talking? Are you looking for exercise, general exercise? Are you looking for therapeutic exercise? You can specify. I guess YouTube holds a whole lot of exercises that you're looking for. And as far as databases are concerned, I know that there is a joint venture of, I think it's also by Physiopedia and somebody, like some other institution, who have like an open source database for physiotherapeutic therapeutic exercises. Stelios was always using this one website for spinal cord injury exercises. I think it's still on his blog somewhere.
Of course, we are trying to build up more rehab-based exercise that are based on evidence. I think the prehab guys, if you don't know them already, they have quite a big collection of exercises. Our friend Mark Cervica has a lot of exercise on Instagram, as well as Teddy Wilsey.
Wesley Wang has a lot for ACL rehab, like specifically for ACL rehab. You can find a lot on Instagram. Dr. Jacob Harden does a lot of nice exercises, good visuals and good explanations for different exercises.
Rehab Science.
Tom Walters, he does a lot of stuff. Adam Meekins also now started posting exercises.
So just start following a lot of those guys and you'll have a bunch of good exercises.
Just check our Instagram and then check who we are following. Not too many people. It's like 110 accounts. Go through them. There are a lot of awesome people.
Right. Manuel Hartmann is actually a name of a guy that I know.
Yeah, maybe he's the guy.
He used to be a soccer professional. Is physiotherapy helpful to restore lower back lordosis? I would argue that I don't think there's any evidence out there that you can restore the lordosis. The bigger question is, why are you concerned about it? I don't think there's a strong link of lower back lordosis because and pain. So there's a general lack of certain postures with pain. And I mean, your back or your lumbar spine is supposed to be in a slight lordosis. So the only thing or the only time when it is an issue is when we have patients for who lumbar spine extension is a problem, and those people are not able to move out of the lower back lordosis or lumbar spine lordosis. Then it would be an issue, and I'd advise those to move out of or give them exercises in direction of flexion to decrease their sensitivity. But for the rest, like posture-wise, I don't think there's a whole lot of evidence that you can correct it. I think we just claim that we can, but or a lot of people claim that they can, but I don't think it's really possible. All right, hi guys. In your opinion, which maniotherapy method is the best? Mulligan, Maitland, Lewitt. What is the difference between maniotherapists and osteopaths? Greetings from Hungary.
I mean, we practice or we learn more of the Maitland technique. So dosage of joint, peripheral joint and spinal joint mobilizations and manipulations in those 5 grades that we also covered. We've only briefly had a lecture on the Mulligan technique. Of course, there's also maybe some anecdotal evidence of using McKenzie directional preferences in patients who experience nerve pain or like radicular pain. So we kind of use a bit of that, but we study the Maitland technique. I don't think that there is the best technique. There are all passive modalities aimed at decreasing pain, increasing range of motion, whatever. I think ultimately with any of those passive modalities, whether that be manual therapy, Mulligan, McKenzie, or Maitland, if you're able to bring your patient to more activity, then the goal is achieved. And how you achieve that, whether that's through mobilization with movement or a Maitland mobilization or manip, I don't think it matters that much.
Yeah, I think personally I don't do too much with Mulligan, also because I don't have the experience.
Yeah,
I think it's a typical Australian approach where it doesn't really matter how it works. They focus, I think, more on that it works. With Maitland, which, like, I think most of most of the manips that we learn and mobilizations that we learn are based on that, like you said. I think we are also trying to focus a lot on the biomechanical and neurological explanation behind that. And what's the difference between MTs and osteopaths? I think osteopaths focus way more on the whole or the holistic. They have a more holistic approach, so I think everything is more connected in their vision. At the same time, I'm not sure how much everything of that school is based on current evidence. So to my knowledge, not too much, but I also don't want to
bash the profession.
Yeah, bash the profession because I just don't know too much about it. So I think it's also a lot about energy fields. But yeah, if we look at reliability studies, and we know that it's already hard to find a certain lumbar level by palpation, and the reliability is pretty low, then I think that also won't score too high in terms of reliability. But yeah, in general, the difference is the focus of an osteopath is way broader. So they also include organ systems.
Exactly.
So it's, yeah. Okay. How would you guys help a patient with distal clavicle osteolysis? No idea, to be honest.
Osteolysis.
I mean, I'm assuming that this person doesn't have a distal clavicle anymore. I would focus on the problems that I see in this patient. So focus on strength, internal, external rotation of the shoulder. Focus on the scapulothoracic muscles. Focus on the impairments that someone is having in daily living. That would rather be my focus than to focus too much on what's going on in the tissues. I mean, if someone took a radiograph of my AC joint, I think it's completely abnormal because I had surgery on it, and if you palpate it, it feels and looks completely different, but I don't have any issues with it. So yeah, that would be my answer to that. Okay, what else? Do you also see the questions?
What do you recommend for pars interarticularis fracture conservative management? So pars interarticularis in the lumbar spine, possibly. Conservative management. Well, I guess that's you can't cast that, so the patient's gonna have some precautions, safety precautions in the fracture healing time. So I guess at least 6 weeks minimal movement. And after that, again, load the bone. And for the spine, it's any weight-bearing activity in the upright position. Start with any movement. Squats. Start with light back extensions. Start with, light deadlifts, whatever it is. What does the patient have to get back to? But how do you strengthen bone? It's through compressive load. And then I would just start easy. Start with bodyweight squats. And load it up.
Yeah, honestly, no idea. I mean, I would also consult with the orthopedic surgeon that decided to go with a conservative treatment, and to ask him what his suggestion is, how much he thinks in this case that the spine can be loaded, what the precautions are. I can imagine that extension in the beginning is a problem.
Yeah.
I can imagine that a lot of rotation is a problem in the beginning. So no idea. Never had such a case, to be honest. Hot pack and cold pack obsolete in physiotherapy. Yeah, I think so. I don't think it has a lot of added effect. I can imagine that with muscle pain, muscle tightness, that a hot pack can give you some relief. I sometimes advise it to patients if they feel it is helping them. Why not? But I don't try to waste my time with it during a treatment session.
Yeah, the patient shouldn't come to your practice to receive a hot pack or a cold pack.
Yeah, I think same story with an acute injury. I mean, we know that application of cold packs can relieve pain, but it can also impair the healing process. So in case a patient has a high pain level, I'd recommend them to use ice in the first, or cold packs in the first 1 to 3 days maybe, but also limit its application, as we know it might impair the healing process.
Yeah, that was really funny with Adam Meekin's ankle sprain recently.
Oh yeah.
That's a good case study. People you could look at. I think he covered it on his Facebook in detail. Ankle sprain during running, big, swelling, hematoma in the ankle, but not using any NSAIDs, not using any ice packs, and just recovering through graded loading again. That was actually pretty cool to see.
Right, small question. When making your videos, how do you guys decide who will be the therapist and who will be the PT?
That's
the role, alternate between the two of you?
No, it's, we choose topics, or we have this Google Drive file where we write down ideas for videos. We pretty much decide ourselves which videos we want to make, and then we write our own scripts for these videos, and then there's no deciding who does what. It's okay, I decide to make this video, so I'm gonna need you as the patient, and you're gonna be the patient. Yeah.
Do you guys have issues like us in America regarding our image as PTs? The APTA's marketing department is awful, and we're constantly battling chiropractors, acupuncturists, massage therapists, and personal trainers. I also think that physios are fighting with insurances a lot, that our reputation is improving, and because I think what happened in the past is that a lot of physios did what they wanted as a treatment, and the insurance companies were paying for it. Now we're in an extreme situation where you have to report everything to the insurance, so they will cover your treatment. So yeah, I think that's kind of a consequence of physios taking advantage of the situation that we're in. I also think that a lot of physios have an ego problem when we compare ourselves to surgeons, because they're the cool ones who they have surgery, they have the scalpel, which is way more fancy than what we do. We're just giving exercises. I don't think that we are battling too much with other professions like chiropractors, acupuncturists, or massage therapists, and personal trainers, because I think that's less of an issue in Europe. With personal trainers, I mean, I think honestly, if you have good knowledge about exercise therapy, you should be able to work as a personal trainer as well. Although I know a lot of physios are bad in strength and conditioning. So I think this is something where physios should get or gain more knowledge and get more involved with. On the other hand, if I compare like what personal trainers are doing, I mean, they have normal people who want to get fit or healthier, and we have patients with an issue who want to know how they can get better, and so we have way more knowledge about the pathological background that PTs don't have. So I don't think there's any battle.
Yeah, I think also what he's referring to, like I picked that up with some discussions on Facebook, how PT is perceived in the general public, even though I think physiotherapy or physical therapy, how you guys in America like to call it, has advanced to a doctorate degree, that the general public is still not aware of the fact that first you have a doctorate, that it's a doctorate profession, that you spend 6-7 years at university getting your degree, earning probably the same amount of credits as somebody who ends up being an MD, people doing residencies, an OCS or whatever, but still the general public overall is not aware of what PT can serve them. I believe that a lot of people still think they go to PT to get a massage and get a hot pack. And I think that's still nowadays maybe rather like the older generation who has for the past decades received physical therapy of that fashion, being lying down, getting a massage, getting a hot pack, and go home with maybe 2-3 exercises with a TheraBand. I mean, it's still a pretty young profession, and I think we're still creating that image, which is why it's so highly important that we work evidence-based to shape that image of the PT being a primary care provider who is on par with the level of expertise as an MD might be in their field of study. And I mean, the US doesn't have universal direct access. I know some states are still battling for that. We have direct access here, so people can come to the PT directly. But yeah, it's I think even here still also a battle of shaping that image of a PT, which is not just the guy who gives a massage and gives you an elastic band and 3 exercises that you do for 3 times 10, 2 to 3 times a week. I think that's still happening. Maybe it's on a bigger scale in the US. Like people getting, angry that you call yourselves doctor, which I believe you have the right to. Yeah, that's it.
Is there enough evidence to convince taping works? No.
but there's enough evidence to convince that taping does not work.
I was trying to look up the last systematic review. Chronic low back pain. I think if you conduct an RCT and you have a really strict placebo control group, and I think this is what the last, I don't find the review, but if you do that, you will see that the evidence, or that it's probably just due to placebo. Still looking up the review. There was a general review.
There was
Rethinking Physiotherapist posted it.
But there was also this class action lawsuit against I don't know which tape manufacturer. Which tape manufacturer it was that they had to pay millions back, or reimburse the costs for the tape to people who bought it, because they, on the box they claim like reduces muscle tone or whatever, and because these claims are unsubstantiated, they had to reimburse that, and they lost the lawsuit.
Okay, I'm actually looking up the post because we also posted it. It was a systematic review, I think, in 2017
for taping.
Yeah,
I'm just gonna check. Maybe it's on
Facebook.
Yeah, on the Instagrams. Because I recently also posted about it. But yeah, there's definitely not enough evidence for taping.
No.
Yeah, let's see here. The study was, that's from 2014.
Okay.
Pereira et al. Current evidence does not support the use of kinesiotaping. Yeah.
That's it?
Yeah.
All right.
There we go. When used for, So synopsis. When used for a range of musculoskeletal conditions, kinesiotaping had no benefit over sham taping and placebo and active comparison therapies. I just pull that up on the screen. The benefit was too small to be clinically worthwhile, or the trials were of low quality. Therefore, current evidence does not support the use of kinesiotaping for musculoskeletal conditions. Some authors concluded that kinesiotaping was effective when their data did not identify significant benefit. And the study, it's right here, Pereira, Costa, Hensnahor, Lopez, from the Journal of Physiotherapy in 2014. It's right here. Yeah.
Okay. There's a follow-up question from Manuel about the lumbar back lordosis. You asked why I'm concerned about my lower back lordosis. The reason being that I have poor range of motion due to flattened alignment of vertebrae. So you think there are no physiological exercises to treat such a case and nurture lower back lordosis? At least there's no clinical evidence. I mean, there's no clinical evidence of posture and pain. So there's such a weak link. And I think the best thing that you can do is exercise. So we know, for example, if you're worried about your vertebrae or your intervertebral discs, that running strengthens the discs, even cycling strengthens the discs, basically any kind of workout. Same with weightlifting. So that's the best you can do. And I think, I don't know why you got worried about it. Maybe because you got an X-ray, or maybe because a health professional told you that you have a flattened lumbar lordosis, but I wouldn't worry too much about it because there's so much variation in posture, and the link to pain is just so low. And if you are talking about range of motion, if I take myself, I am not very mobile, especially in the lumbar spine. I'm pretty stiff, but I'm not worried about it. I think in a lot of cases, less range of motion means more stability. And if you're really mobile, I think that's more a risk to develop any issues in the future than less range of motion in a lot of cases, generally speaking. Okay. Can you teach about chondromalacia patellae? I mean, it's basically the same like patellofemoral pain syndrome. It's sensitivity of your cartilage on the backside of your patella. And we made a lot of videos about the diagnosis, which is a diagnosis of exclusion. There are a couple of clusters out there, not very accurate ones. But basically the treatment would be to do strength training for your hip abductors, external rotators, and your quadriceps. And if you are currently suffering from patellofemoral pain syndrome, a really important issue is load management as well. So you should try to remove everything that is stressing your patella too much. So remove load. If it's from cycling, walking stairs, weightlifting or whatsoever, reduce the load and try to build it up with the exercise approach that we just mentioned. For example, in our case, what we said earlier, remove the load in your squat, for example, until you can squat in a pain-free manner to reduce the sensitivity of your retropatellar cartilage and then build it up slowly, because your body is adaptable, and even if there is some signs of retropatellar or damage to the cartilage, doesn't have to equal pain. So no,
nothing to add. Calm it down and then gradually build it up.
Okay, next question. How do you guys keep a balance between implementing an evidence-based approach to treatment and also maintaining a happy client base? Emerging research seems to promote an exercise long-term approach. Yeah, that's a good one. Therapy, but clients don't seem to be too happy unless you end up prodding around on their body.
Yeah. It's a fine balance. I think it depends, some patients don't require a lot of buy-in or a lot of different approaches until they buy into the suggested treatment. In the end, it's the client's decision whether they want to follow. You don't have to dictate. I mean, you're not a dictator. It's a shared decision-making process. I think you as the therapist, you have a treatment approach in mind, which in what you describe is as evidence-based as possible. And I think if you outline that to the patient thoroughly, they either buy in or they don't. There's like I said, this fine balance. Maybe it requires finding a common ground of saying, okay, maybe we do some of that prodding for now, because it's also plays in, I think the client's expectation also plays a big role in the effectiveness of your treatment as a whole. And if you can get them to follow this long-term exercise, being active and being in control of their own treatment outcome, which is getting active, if there's some prodding involved or some manual therapy, heck, even applying a tape that allows them then to go onto the trajectory of exercise therapy, then that's okay. But if, of course, we had those patients who absolutely will not stop asking for the treatment that they think they need, even though in the long term we know it's not going to change anything. You can't get too caught up. You provide the plan. Here's the game plan that I think is going to get you better. And they either understand it and agree and want to work with you. But some patients just don't understand that physiotherapy is something you do and not something that you get. Then those patients, you can't help everybody. But it depends on how you create that buy-in. And if people don't want to buy in, then that's too bad. I think you can get too caught up.
Yeah, I agree. Yeah, in short, I try to convince them with evidence and with a good explanation. And if I feel like patients are not willing to accept my approach, I sometimes go a bit with them in the direction that they want to go towards, and then slowly try to shift them into the direction of an active approach. But yeah, like you said, sometimes you don't reach all the people. And then the question is, and that also depends on your setting, I think in some cases you can just tell them that they should see a different physio. In other cases, I think you have done the best that you can. You try to connect with the patient and try to give them the best option. If they still don't think that that's what they need, then I'm not, at one point I have to protect myself and not be responsible for their outcome at one point, because I feel like you can also destroy yourself as a physio if you try to, or if you have to go against the will of 8 patients a day. That's going to destroy you at some point. So either you drop them or sometimes you kind of give it up.
I don't think you should get too caught up.
Okay, let's see.
Just put them in a dark room with a hot pack.
You guys do a very good job in making videos about individual joint assessment. Is it possible to make videos more on a treatment aspect? Yeah. Well, if you have it about individual joint assessment, maybe you have it about manual therapy. I think in general about assessment, but we're doing more and more treatment videos. For sure.
Our exercise playlist is growing.
Okay. Yeah. I'm just going to go through them quickly. There's not a lot of questions left, but that's perfect because the timing is perfect. 2 more minutes. Is there any evidence about ultrasound as an effective treatment for tendinitis conditions? No, it's not. If you're curious about other passive modalities, then you could look into, how's it called? Shockwave therapy. There is some evidence for that. But for the rest, again, it's good load management is key for tendons. Tell us about trigger points and how to release the trigger points. That's a huge story because there's already the question what trigger points are and the problem that we can't reliably find them. So some say it's a taut band. Others say it's more of a neurological condition. And how can we treat them? I mean, there's dry needling, there is manual pressure, there is stretching. So there's a lot of different approaches. But the problem is that the theory about trigger points is still kind of unknown and that we can't reliably find them. So, I mean, we do release trigger points sometimes, but that is like the very exception. And it would never be the sole treatment because you also have to ask yourself what the underlying problem is. And that's usually a strength issue or an overload issue.
Yes. One thing, if you want to definitely check out these guys, Neuroortho-based approach on Instagram. They also have a Facebook page. They've done a pretty cool series on trigger points. Also the assessment and treatment theories behind the etiology of trigger points. And then also more recently, they've done a great series on tendinopathy. So you can check them out on Facebook or on Instagram.
Okay, Hashmi is saying congratulations for 100,000 subscribers.
Thank you.
Thanks a lot. Any must-have physiotherapy apps we should know about?
Of course, there's a great app.
Physiotutors. Now, of course, we have our Physiotutors assessment app that you can get on the App Store and Google Play. Apart from that, I don't really use too many apps. I think a really handy one is the inclinometer.
Yeah.
So you can reliably measure range of motion, and it's free. So those would be good. Kindly do some videos on the Schroth or Schrod method for scoliosis. I know that's been requested a lot, and I promise that we'll look into it. Please suggest how to manage knee valgus. I mean, the question again, that's the same with posture. Why should knee valgus be of any concern? If you have knee pain, okay, I get it, but then still, if we manage the valgus with external rotation exercises and abduction exercises of the hip, we do see that those patients get better, but we also do see that the knee valgus doesn't change. So I don't think there's a lot of evidence that we can change posture or biomechanics, but we can,
even anatomy. Have a higher Q angle of the hips, resulting in more knee valgus simply due to your bone morphology. So you're not going to be able to correct that.
Okay, does Shockwave work on trigger points? No idea. I don't think so. It's designed for tendons and especially calcification in tendons. And again, we cannot really reliably find trigger points. We don't know what they are. So no idea. And the last one before we close. It is said a TENS machine can be applied to any pain area except some few conditions. Similarly, which are those techniques or exercises which we can apply to get quick results? I mean, I don't think there's a lot of evidence for TENS either. The only application I can imagine is in central sensitization. And if you can't do any exercises with those people, then via the gait control mechanism, I can imagine that it's decreasing the pain in some patients. But for the rest, we don't really use it, and I don't think there's too much evidence behind it.
Anything else?
Person to the left reminds me of Michael Fassbender. I heard that one before, actually.
Yeah.
From Nick. Yeah.
Did you look like Michael
Just
Fassbender?
to make it a little lighthearted for a bit. Person to the left, me, I guess, Kai, reminds me of Michael Fassbender. aka Young Magneto. Person to the right could be a buff young Professor X.
Professor X is from X-Men. Should I be in a wheelchair?
No, it's actually funny that you say that, because our former housemate also said that I was looking like Michael Fassbender. Not too bad, actually. So
Wait.
I don't think there's too much resemblance, but it's actually the second time I hear it. So but he's a ginger, right? So I'm not a ginger.
Yeah, he with black hair.
I think he's Irish, German, something descent.
Okay. Turn to the right and to the left.
Okay.
All right. That's a good frame to close this live stream on, I guess.
Robin van Persie, will you be up for a conference to the University of Barcelona this year? We offer the beer. I mean, send us an invitation and we'll see. But we got a pretty
tight schedule,
busy schedule this year, because we're also finishing off our masters in the coming year. So I mean, send us an invitation via Facebook, Instagram, or YouTube, or via email, and we'll see. All right. I think that concludes the fourth live stream we have. Maybe as a short reminder and to finish off, we just released our version 2.0 for our orthopedic assessment book. We increased the number of pages from around 430 to almost 500 pages now. We added a lot of statistics, but even more videos that we made in the last half year. So the book is growing and it's improving. If you want to get it, you can find it on our webpage physiotutors.com under the book section. We are also trying to update our app. Which we're currently, we're experiencing some problems with the update feature. So our programmers, they are working on it.
The wizards.
Yeah. So that's going to happen next week. I think they're going to start. So the update should come soon as well. The app will contain the same videos that we have in the book. And we are still working hard on our first orthopedic assessment course, which will be an online course where we put all our knowledge in one course. So it's going to be the book and the knowledge from the app, but also from our masters and from our clinical experience and a lot of evidence into one orthopedic assessment course where we cover different joints and the most common pathologies and how to recognize them, to learn about the pathophysiological mechanism behind it, epidemiology, incidence, prevalence, prognostic factors, how to recognize them in patient history taking, assessment, of course, and in some sections we're also giving treatment advices. So it's going to be a huge course. It took us more than 2 years to build it up to now, and there's still some work to do. So this is something we're planning to release in October, hopefully. Fingers crossed. That's it for the announcements. I don't know if you have anything to add.
Not really. Everybody who's going back to school these days, good luck. Enjoy. Make the best of it. Send us any questions you have. And thanks for sticking around on this Saturday afternoon from wherever you may be watching. We're going to schedule the next live stream for in about 4 weeks because we want to do this once a month. So maybe beginning of October.
It's going to have to close. I think it's going to be end of September. Otherwise, I won't be able to join. We're going to be in Sri Lanka for 3 weeks. So,
it's going to be me by myself. No, it's going to be end of September then, before Kai leaves for Sri Lanka. Yeah, thanks for tuning in again.
If you still have any questions that remain unanswered, you can always reach out, send us an email, contact us on Instagram, Facebook, or on YouTube.
Or write them here in the comments, because this video is going to go up on the channel in the next couple hours then. All right.
All right.
Guys, thanks for tuning in.
Enjoy your weekend.
Have fun.
Bye-bye.
Bye.